Before entering the room, our nurse will wash his hands. He will introduce himself to the patient, explain the procedure, as well as the length of the procedure. He will identify the patient, verify MD orders, and ensure that consent has been signed. Venous access must be established with an 18 or 20 gauge needle. It must be at least 20 gauge to prevent hemolysis. Before starting the transfusion, our nurse has assessed vital signs, urine output, and a history of any transfusion reactions. It is essential that another nurse assist in verifying the correct blood for the correct patient. This is done by checking two patient identifiers, checking that the CTX number matches the blood and the patient band, the unit number matches blood and the paperwork, the blood type is compatible with the patient's blood, and the blood is not expired. It is important that the blood be hung within 30 minutes of receiving the blood from the bank. The procedure begins by spiking and priming the Y blood tubing with normal saline. Once this is done, the normal saline will be clamped. Our nurse will then be able to spike the blood and start the infusion slowly at a rate of 2 milliliters per minute. It is important that the nurse stay with the patient for the first 15 minutes after the infusion has begun. This is essential because there are many transfusion reactions that may occur. Some include an acute hemolytic reaction, which is a medical emergency, an anaphylactic reaction. These two will usually occur within the first 15 minutes of the initiation of the transfusion. Other reactions include a febrile, mild allergic reaction, hyperkalemia, or circulatory overload. It is very important to observe the patient for signs of a reaction. These signs may include fever, chills, elevation in temp, nausea, itching, flank pain, and anxiety. If a reaction occurs, immediately stop the infusion, keep normal saline running, call the MD and blood bank, and be prepared to administer emergency meds. It is crucial that the nurse stay with the patient for the first 15 minutes after the infusion has been initiated. Take first vital signs in 5 minutes after the beginning of the infusion. Take them again in 10 minutes. If no reaction has occurred, it is possible to turn up the blood. Run at 150 ml per hour to infuse in 2 hours, or 75 ml per hour to infuse in 4 hours. Take vital signs every 15 minutes. Our nurse will document per the facility's policy. Hematocrit and hemoglobin may be checked afterwards, seeing as these will both be affected. Once the infusion is finished, discard the blood and tubing into a biohazard bag. Before entering the room, our nurse will wash her hands. She will introduce herself to the patient and identify the patient. She will explain the procedure, how long the procedure will take, and ask the patient if she has any questions. During this procedure, she will be drawing blood from a central line, flushing a central line, changing the dressing, and assessing for any complications. First, she will be drawing blood from the line. She will assess all medications and infusions before selecting a port for sampling. Both the patient and nurse must wear a mask during this procedure. It is important to clamp the catheter and disconnect the infusion from the entering port that is being sampled. Using vigorous friction for at least 15 to 30 seconds, she will prep the site with chlorhexidine and let it dry thoroughly. Lower lock the syringe and unclamp the catheter. Confirm if the indwelling line contains heparin. If obtaining specimens from an indwelling line that may contain heparin using a 10 or 12 milliliter syringe, first flush the line with 10 milliliters of normal saline using a pulsatile push-stop motion. Remove the syringe and clamp the catheter. Attach a new syringe and withdraw the first 5 milliliters of blood, or 6 times the line volume, and discard. With a new syringe, withdraw a volume of blood equal to the total amount of blood you will need for all blood samples. Using a 10 or 12 ml syringe, flush the catheter with normal saline using a pulsatile push-stop motion. If there is an infusion, it is now safe to reconnect it. If there is no infusion, flush with heparin per procedure or protocol. Reinstitute all infusions that were shut off prior to the blood draw. Flushing the line is important to prevent blood from clotting and blocking the catheter. After cleansing with an alcohol wipe, you may attach a 10 ml syringe and flush each line. Never use the same syringe a second time. If there are 3 ports, 3 syringes must be used. If caps need to be changed, you can do it at this time, just ensuring that the catheter is clamped to prevent air embolism. When performing a dressing change, ensure that the patient is in a semi-Fowler's position if tolerated. The patient must wear a mask, and if this is not tolerated, ensure that the patient has their head turned to the opposite side from the insertion site. Carefully remove the old dressing and inspect for complications. You should assess for an air embolism, which is an air bubble that enters the blood vessel. Signs of this may include decreased blood pressure, lightheadedness, confusion, increased heart rate, anxiety, chest pain, or shortness of breath. Assess for an infection, which would present with fever, chills, tachycardia, fatigue, muscle aches, redness, swelling, and drainage. Assess for phlebitis, which would present with redness, pain, streaks, or drainage. And other complications, which include catheter malposition, difficult removal, nerve injury or irritation, leakage, and catheter breakage. A sterile central line dressing kit has been obtained. Sterile gloves must be worn for the procedure. Our nurse has realized that she may break sterile technique. She utilizes her resources in order to prevent this. She then cleanses the insertion site with an antiseptic swab. If using a chlorhexidine-containing product, which is preferred, she uses a back-and-forth motion and friction for at least 30 seconds. If she uses alcohol or 2% tincture of iodine, she starts at the insertion site and works outward 2 to 3 inches in a circular pattern. She would scrub the catheter hubs, tails, any suture, and any exposed catheter with the sterile swab. Allow the site to dry thoroughly. Carefully apply the transparent dressing. If a catheter stabilization device is available, one would be used. Gently secure the catheter with tape. Label the dressing and when it needs to be changed, the time and initial. Dispose of all supplies in appropriate receptacles and document the procedure.